that's not switching the slides. Oh, there it is. Okay, perfect. So my objectives for today's talk are fertility considerations in breast cancer. We'll talk about the safety of fertility preservation as well as pregnancy after breast cancer. And then we'll jump into managing bone disease in breast cancer, with really focusing on aromatase inhibitors, treatment and prevention of bone loss, as well as bone medications to reduce the risk of breast cancer recurrence, as well as bone modifying agents in metastatic breast cancer. So we think about fertility preservation at the time of a cancer diagnosis. It's really important that we consider fertility. So often there's so much going on. We're talking about chemotherapy and surgery, and sometimes it kind of gets pushed aside, and it really, really needs to be discussed. It needs to be part of the consideration before initiating any gonadotoxic treatment or surgery. And all patients who are of reproductive age and who have even a remote consideration that they might want to think about fertility should be referred to a reproductive endocrinologist and infertility specialist. Sometimes people say, well, I'm not sure, and we just jump right in, but really it doesn't. If you have a good relationship in your practice with that team, getting them for a consult is really, really important. And these conversations must occur as early as possible. We know fertility preservation takes time. It is cost prohibitive in certain situations, and so it can delay initiation of cancer-directed therapy. But if this is a patient's goal, it is our duty and our responsibility to make sure that we address it. Now, of course, a common concern is it safe? This is something that patients ask me all the time. Is fertility preservation safe? Is delaying my treatment going to impact my outcomes? And so there's a lot of data on this. A good study that I want to highlight is a nationwide study of 425 Swedish women, and they underwent fertility preservation at the time of their breast cancer diagnosis. And actually what they found was that fertility preservation was shown to be associated with a higher amount of live births after diagnosis and treatment compared to people who didn't undergo fertility preservation, and there was no impact on all-cause survival. So we can be comfortable telling our patients that this is safe, that prolonging their treatment for a few weeks is not going to make an impact. Similarly, when we think about outcomes with or without hormonal stimulation, it is not associated with an increased risk of relapse or cancer-specific survival in women with breast cancer. And furthermore, it's not impacted by the typical prognostic factors that we think about: estrogen receptor status, tumor size, lymph node status. So really anyone should be offered this. Switching gears a little bit, when we think about fertility and pregnancy after breast cancer, the guidelines kind of vary at this point and how long we want to wait until we've completed our active cancer treatment. Some will say 6 to 12 months, some will say even longer, and a lot of this depends on the treatment that they received, as well as the risk for recurrence of prognostic factors. We know that at least have to wait 3 months after cessation of endocrine therapy, and I'll talk a little bit about interruption of endocrine therapy. 7 months after cessation of trastuzumab due to trastuzumab-related oligohydramnios to the fetus, which can result in pulmonary hypoplasia and neonatal death. But still, pregnancy after breast cancer is safe. There's a very large 2021 meta-analysis published by Matteo Lambertini et al., and it looked at over 100,000 patients and with breast cancer, including over 7,500 who had had a pregnancy after their breast cancer diagnosis. And the bottom line from that study is that pregnancy does not impact breast cancer survival. And that's really, really important because so many patients are nervous about attempting pregnancy after. Will it cause their cancer to recur? And we have this really great data that says it will not. I'm going to highlight a few key points from that study. So the one thing that I like that they did was they looked at what is the likelihood of pregnancy after a cancer diagnosis. And you can see all the different cancers up there. Breast cancer is kind of, you're less likely to achieve a pregnancy after a cancer diagnosis from breast cancer, in part because of the therapies that we use. Cervical cancer is kind of the least. So I think it's an important point to highlight to patients that, it's not going to be easy, but if this is a goal, we can make it happen. We can do everything that we can to try to make it happen for them. And the slides are up on the app, which you can zoom in and kind of see in more detail. When we think about reproductive and fetal outcomes of patients with pregnancy after breast cancer, so what patients want to know is, sure, it's safe, but how is this going to impact my fetus and my offspring? And so what we know is that there's no difference in pregnancy complications, but patients with breast cancer do have a higher risk of C-section. They have a higher risk of low birth weight, preterm birth, and small for gestational age offspring if they've had breast cancer before. So it is an important point to counsel patients on about what they can expect. But really, really importantly, and this is what we all want to know, is that there is no increased risk in congenital abnormalities. So that's a big point. So yes, they might have smaller offspring, they might have a preterm birth, but actually that has long-term, due to multiple registries that exist, have not been shown to impact survival and the life and the quality of life of these babies after they're born down the road, and no congenital abnormalities. Now, what about maternal outcomes of patients with pregnancy after breast cancer? And so interestingly, in this analysis, they showed that patients who had a pregnancy after a breast cancer diagnosis did better. They had an improved disease-free survival and improved overall survival. Now, some of this is still being worked out. It's not clear if the patients that did attempt a pregnancy were the ones whose cancer didn't recur, who maybe were healthier, and things like that. But I think the point here is not to say that you're going to do better and so you should get pregnant. I think the point is to say that it's safe and you're not going to see a detriment in your survival. And again, the lack of harmful effect of pregnancy was observed regardless of the prior treatment they received, regardless of their lymph node status, timing of pregnancy after breast cancer, BRCA status, and also pregnancy outcome. So that was important. Now, the big question that really remains is going to be the results of the positive trial. So the positive study is looking at when can we safely stop endocrine therapy. We know that we used to recommend 5 years of endocrine therapy, now we recommend 10 years. So if you have a let's say 33-year-old woman who's going to be on 10 years of endocrine therapy, well, that she may want to have children during that time, right? So when is it safe to do that? And so the positive study is going to hopefully answer that question for us. In this study, they enrolled patients who had stage 1 through 3 hormone receptor positive early stage breast cancer who were under the age of 42, and they had to have received endocrine therapy for at least 18 to 24 months. They have a 3-month washout period, and they're going to be allowed to attempt conception, pregnancy, breastfeeding for an interruption of total of 2 years, and then they have to resume treatment. And they're going to look and see what happens with these women. What's the timing? Is it safe? And I think this is really the missing gap in this field right now because we just don't know what to do with these patients. So a lot of us in practice have been modeling after the positive trial, but it'll be really nice to see the results. So, and I think that the key here is that in a study looked at 33% of women who were 40 years old and younger, fertility concerns impact their decision about starting endocrine therapy or continuing on endocrine therapy. That's a big issue. We know that endocrine therapy is the backbone of treatment. And so if a third of our patients aren't either going on it or stopping early, that's a big concern. So now we're going to switch gears and kind of go to the other end of the spectrum and talk about bone disease. Now, when we think about bone disease and breast cancer, our mind's always going to aromatase inhibitors. But I do want to point out that there are other treatments and other medications that can impact our bones: chemotherapy, other targeted therapy, ovarian suppression in the younger population. But the greatest risk when we talk about the postmenopausal population is going to be aromatase inhibitors. Now, aromatase inhibitors increase bone turnover markers, including markers of bone resorption and bone formation. And they're all listed there. Now, we're not at a point where we're monitoring these in clinical practice. A lot of patients will say, well, is there anything else you can do besides my DEXA scan? But we don't have any guidelines about checking these routinely. And we don't see this change with tamoxifen. So when we think about bone loss and fracture risk, there are a number of studies that have been done to demonstrate that aromatase inhibitors increase fracture risk compared to tamoxifen. I'm not going to go through all these ones in detail. You can look at the slides with all the information, but 2 points to make. In some of the studies, that patients who had a normal bone density, at the end of their treatment of aromatase inhibitors, they didn't develop osteoporosis. So they may have developed osteopenia. So an important point to counsel patients is that if they're really concerned, but they're starting out with a normal bone density, it may worsen, but it may not overtly progress to osteoporosis. And the other part in terms of risk discussions and risk counseling, what we can say to patients is that compared to tamoxifen, aromatase inhibitors increase our risk of fracture by a relative risk of 47%. So that's not a small number. And if you've counseled patients on tamoxifen versus aromatase inhibitors, we all know that bone disease is really top concern of patients. I had a conversation yesterday with someone who said, I don't think I'm going to take this. I already have osteopenia. I'm worried about what will happen. So the question is, and what I always tell patients is, let's think about not just your bone density, but your fracture risk. So let's talk about that. People will look at that bone density report and they'll say, all right, I have osteopenia, that's it, I'm doomed. But it's not just the score on the DEXA scan. So the DEXA scan is important, but it's all the other clinical factors. So you may have two people with exact identical DEXA scan score. One of them is going to be at higher risk of fracture than the other. And so how we figure that out is, first of all, looking at someone's clinical risk factors for fracture. So what about them is going to make them at higher or lower risk? That includes age, so advancing age, higher risk of fracture. If you've had a prior fracture, if you've been on steroids, and a lot of our patients on chemotherapy have been on a lot of steroids, or they might have had steroids for other reasons, autoimmune conditions, things like that. If they have a parental history of a hip fracture, that's going to be a huge risk. Low body weight, smoking, alcohol use, and we're counseling people on that anyway, but yet another important point to counsel on to reduce our bone health risk, rheumatoid arthritis, and then secondary causes of osteoporosis as well, so such as inflammatory bowel disease. So we're going to take our DEXA scan score, we're going to take the clinical factors, and I think we don't do this enough in clinical practice, but we plug it into a tool, a calculator, right, that can quantify a patient's risk for them. And one of these, the most commonly used, is the FRAX, or Fracture Risk Assessment Tool. Now, a lot of places, when you go to get a bone density, they will actually calculate this for patients, but if they're not, it takes a few minutes, but I think it can be really helpful to plug into for the patient. Now, you notice that aromatase inhibitors aren't anywhere on this list. They're not actually in the FRAX calculator. They're not on the clinical risk factors for fracture. And so this tool that exists actually has not been validated in breast cancer, and we don't have a tool for breast cancer patients. So what has been proposed and has some data is that you check off that the patient has rheumatoid arthritis, because that's kind of thought to be a comparable risk if they're going to be on an aromatase inhibitor. So you're doing it with the patient, you're checking the box for RA, and that should give you a little bit more information. So we have this information. What do we do about it? Now, first part is talking about non-pharmacologic management, and I find that this is really, really important because you've just put patients on chemo, radiation, surgery, endocrine therapy. They, a lot of times, don't want more meds. They're done. And so the key is the non-pharmacologic piece of it. And so number one is, well, do they have any other causes of osteoporosis? Very often you'll do a scan and you get this really severe osteoporosis. So we should start looking for, is there something else that caused it? Then we jump to lifestyle changes. Physical activity is huge. Big, big, big. So balance training, flexibility, stretching, endurance exercise, resistance or progressive strengthening exercise. And I find that patients have no idea what all of this means, and it's really important for us who, as doctors, as providers, is to give patients a tool, whether that means setting up programs with a local facility, bringing in trainers, bringing in educational seminars for patients so they know exactly what to do. What we've done at our practice is our hospital has a medical facility, a medical gym, and we have exercise specialists, and we send our patients there and they get an assessment, and then they get an exercise prescription. They literally get a piece of paper handed to them that says, this is what you should be doing. So that the next time you go to either this gym or any gym of your own, you know, okay, they told me I gotta do, squats, or I gotta do lunges, but at least you have a tool, because if you put people into a gym who've never worked out before, they're gonna walk right out of it. In addition to exercise, so alcohol, smoking cessation, huge, and we know that alcohol and breast cancer is a big modifier that we can do. And then calcium and vitamin D. And this is really, really important. And in calcium, we're talking about, the recommendations are 1,200 milligrams of calcium, which is diet and supplements, and then vitamin D levels as well. Now, when we switch to pharmacologic management, obviously we are aware of bone-modifying agents. The big ones are either bisphosphonate or denosumab. There's different guidelines that are available about when we should consider bone medications to just, we're not talking about risk reduction, we're talking about just bone health here. And the guidelines vary in terms of if you have to have this T-score, that T-score. What it really boils down to is if a patient has osteoporosis already, or they have osteopenia with a clinical risk factor for fracture, we should be talking about these medications with them. In terms of what they are, again, like I said, either bisphosphonates or denosumab, both are going to be well tolerated. They have generally mild and manageable adverse events. The big issue is cost and insurance coverage concerns. These medications are not cheap. Even if insurance covers, they have a high out-of-pocket for a lot of people. So a lot of times we'll use the IV bisphosphonates over the oral. There's better data for the IV bisphosphonates in terms of the risk reduction from breast cancer, which I'll get to in a second. And with denosumab, it's important to remember and counsel patients on that there is a rebound effect after we discontinue the medications. So most patients actually then have to go to a bisphosphonate. In terms of the benefit, bisphosphonates versus denosumab, hard to read here, but the point is that they're overall very effective in reducing risk, up to 50% in terms of reducing our risk of fracture. Now, in terms of reducing the risk of breast cancer recurrence, ASCO has a really nice guideline about this that came out earlier this year. And we know that, okay, these medications reduce our risk of fracture, but what do they do to breast cancer recurrence in the bones? And in fact, that they do reduce the risk of breast cancer recurrence. It's not going to be for everybody, but what I like is the way that ASCO wrote it. And they say that every postmenopausal patient, and it's important to know that postmenopausal here is defined as natural or induced with ovarian suppression, who has any breast cancer should have this discussion about use of bone-modifying agents. It doesn't mean we're going to put patients on them, but it means we should have the conversation. Why are we not putting all of our patients on it? Well, number one is access. So this is huge. These are expensive medications. Very often, insurance will not cover unless they also have an underlying osteoporosis. Availability. And like I said, a lot of times people said, I can't do one more thing, okay? I draw the line at this. What I like to use is the NHS Predict tool. It's a tool based in the UK, but you can plug in the different treatments that patients are going to use, and it'll actually give you a risk of bisphosphonate therapy, the benefit of bisphosphonate therapy. So this is going to reduce your risk by another 2% or another 5%. And I think that can be helpful with patients in terms of how to have these conversations. What are we considering whether we offer these medications or not? The risk of recurrence, risk of side effects, the financial toxicity, drug availability, patient preferences, comorbidities, et cetera. And I will just say, if you're doing this only for breast cancer risk recurrence, ASCO guidelines currently only recommend bisphosphonates for this due to inconsistent data with denosumab. A lot of people will still use denosumab, but just kind of keep that in mind. I'm going to just jump through these next slides here, just for time purposes, but they're all up in the app. And bone-modifying agents in metastatic breast cancer, this is really, really important. Bone is the most common site of metastasis in cancer and also very prevalent in metastatic breast cancer. And bone metastases have a lot of complications: pain, decreased performance status, decreased quality of life, and skeletal-related events. The need for radiation, surgery to that area, pathologic fractures, cord compression, hypercalcemia. So it is really important that we offer and discuss and treat these patients. Bone modifying agents will reduce the risk of skeletal related events and also associated with a modest improvement in pain. So definitely make sure that we're keeping that in mind. And so in conclusion, fertility preservation, a key component of breast cancer treatment for patients of reproductive age. It is safe for both the mother and the fetus, and it does not impact survival, both at the time of diagnosis and pregnancy after a breast cancer diagnosis. And when we think about bones, bone loss and increased fracture risk are huge complications of aromatase inhibitors. And we really, really must be advised and prepared to counsel patients on risk reduction. So thank you.
We actually have a question from the virtual audience. It asks, what is your current approach to the patient in adjuvant endocrine therapy who wishes to get pregnant? And are you using GnRH against during chemo for ovarian protection?
So great question. So in terms of on chemotherapy, I will always use GnRH agonists. I use Lupron typically for patients who are getting during chemotherapy because that has been shown to be associated with a higher amount of births after chemotherapy. But I usually will tell people that if some patients will say, like, I'm kind of thinking about it, I will just do Lupron. But if it's a really important point, I will make sure they do fertility preservation and then Lupron during chemotherapy. And in terms of patients on endocrine therapy, what I have been doing in my practice is modeling based on the positive study. So that's 18 to 24 months of endocrine therapy, 3-month washout period, and then allowing patients to attempt conception.
I have a lot of patients that can't afford the fertility preservation.
Yeah.
Is there any organizations, or I've been asked this a lot, if there's any organizations that give to that?
The one that I know and we work with is Live Strong. They have a lot of grants for patients, but that's still very expensive. Chick Mission is an organization started in New York City by a breast cancer survivor. It's a fantastic organization, and their mission is to make sure that not a single patient pays for reproductive services. So that's a great place to reach out to. I would encourage anyone to, there's just kind of Google. Honestly, there's a lot of organizations that we don't know about that can help, but that requires a lot of work and time, right? Patients are overwhelmed. We don't have the time to do it. And I think this is a huge unmet need in terms of coverage, and we need insurance coverage for full reproductive services.
In terms of bisphosphonate therapy and rank ligand inhibitor therapy, one of my biggest challenges is with dental health.
Yeah.
And it is a tremendous problem when patients develop osteonecrosis of the jaw, and then even before you start the therapy, you're checking out their dental health, and you're very worried about starting them on those therapies. What has been your strategy?
Yeah, so, I think kind of two pieces to that. I think patients, osteonecrosis of the jaw is a scary term for all of us. And so I think I always counsel patients that the risk is very low, and in some studies even 0%. So it is low, but I will ask all my patients to get dental clearance before they go. I have a form letter that I have in my clinic that gets printed out to the patient so they don't have to go to the dentist and go, they wanted me to be on this medication, I don't remember what it is. So that helps. But and I think that it's all about, I do have some patients who need a lot of dental work, right? And then it's risk benefit. If they have a lot of bone, if they're metastatic and they have a lot of bone disease, we'll maybe weigh the risk and say, you know what, I think the medication's gonna be beneficial here, your high calcium levels, things like that. Someone that has maybe a 1% to 2% benefit, maybe we don't do it. We're really focusing on everyone, especially I'm focusing on the physical activity, weight-bearing exercise, because I think that's something that they can do, that they have control over, that you can modify your risk.
Thank you so much.
Thank you.